Hello, hi. Welcome back to another session. As we discussed in the previous session, we'll be discussing on liver tumors and especially hepatocellular cancer in this particular session. And I think there are some students who have already joined. May I know how many of you have joined already? First of all, my audio and video is clear. Hello, Ankitya. Yeah, audio and video is clear. Not a problem. Cool then. Okay. Thank you for confirmation. Let us move on to the liver tumors, by the way. So basically, we are going to divide into benign liver tumors and malignant liver tumors. Benign and malignant liver tumors. So first, let us finish off the benign ones. Then we'll move on to the malignant ones. Malignant, of course, the most important of all is the HCC, which has to be known in detail because there are few cancers that are important for exams. Probably the first cancer that is important for exam would be the breast cancer, of course. And the second cancer is going to be the lung, and third is going to be the liver, and fourth is probably the prostate. So there are 4-5 cancers which you need to, apart from the hematological neoplasms. You can never forget the hematological neoplasms. Of course, that is really, really important. In that, the most important is going to the multiple myeloma. But compared to the non-hematological neoplasms, when it comes to it, so liver is one of the very important cancers. So let us start with the benign liver tumors first. So whenever you talk about a benign liver tumor, you know what are the three most commonly asked liver tumors in exams. One is going to be the hemangioma. Second one is going to be the FNH, that is focal nodular hyperplasia. And third is going to be the hepatic adenoma. These are the most commonly asked questions in exam. But if you ask the most common tumor of the liver, it's always going to be the hemangioma. Hemangioma is going to be the most common benign tumor of the liver. At the same time, it is the most common tumor of the liver also. The overall incidence of hemangioma is approximately around 0.4 to 20%, depending on the population which you are studying. Indians, you have a incidence of approximately, like 3 to 7%. That's the incidence in Indians. But worldwide, depending on the geographical situation, the incidence might be highly variable. And as I told you, FNH is going to be the second most common, but still it's not that common at all. Especially in India, it's very rare. And hepatic adenoma, it's a very uncommon and a rare tumor. The rarest of all benign tumors, if they ask you, answer will be hepatic adenoma. Especially in Indians, it's even more rare. All these tumors, all these benign tumors, like hemangioma, FNH, including hepatic adenoma, are common in young to middle-aged population. Young to middle-aged population. Middle-aged population. And all of these tumors are basically more common in females compared to males. So ratio is approximately 6:1. Female-male ratio 6:1. And they are very, very common in females. Usually very rare in males. Next, coming to the etiopathogenesis. So what is the pathogenesis and what is the reason for development of these tumors? We know hemangioma arises due to some congenital vascular malformations. And in that, there is one small MCQ point is there. Basically, these vascular malformations, they enlarge into tumor by something called as ectasia and not hyperplasia. Remember, these are not hyperplastic vessels, but these are ectatic vessels. These are enlarging by ectasia and not by hyperplasia. Very, very important. Not by hyperplasia. They are enlarging by ectasia. Multiple times asked question. It's an old question, but still it's multiple times asked. Before 2010, it's a very common question to be asked in exam. And apart from that, FNH wise, if you see what is the reason for development of FNH, so there is some hypothesis and theory for development of FNH. It's proposed there should be an injury to the portal tract, either microscopic or macroscopic injury to the portal tract. It could be a focal injury, not a diffuse injury. Diffuse injury will result in a different response, not FNH. So it must be a probably focal injury, which typically is congenital in nature, a congenital injury to the hepatic tract, or probably due to a congenital anomaly, which produces hypoperfusion to the hepatocytes. And this hypoperfusion will result in a hyperplastic response. And especially at birth, this kind of response are very common. Hypoperfusion leading to hyperplastic response. And there won't be only hyperplastic response of hepatocytes. There also will be something called stellate cell activation. stellate cell activation. And this stellate cell activation along with hyperplastic response is the one that is responsible for the formation of this central scar. In fact, the central scar that is very characteristic of focal nodular hyperplasia, in exams at least, is going to originate from this stellate cell activation only. So this is the mechanism of development of focal nodular hyperplasia. As far as hepatic adenoma is concerned, we really don't know why these things are happening. But there are multiple risk factors and a lot of mutations have been identified, which we'll be discussing in some time. And there is something called as molecular classification of hepatic adenoma as well. If you know that molecular classification of hepatic adenoma, you will be understanding what are the mutations that are commonly seen. The first one is going to be the HNF1 alpha mutations. You would have studied this HNF mutations in MODY, maturity onset diabetes in the young as well. But the same HNF1 alpha mutation that is associated with something called MODY type 3, maturity onset diabetes in the young type 3, which is the most common form of MODY, is also associated with hepatic adenoma development. Clear? So remember, these patients will have MODY. This is the most important thing that you need to know with regards to HNF1 alpha. Plus, they will be having hepatic adenomas as well. I mean, adenoma in the sense, I'm talking about hepatic adenomas here. And at the same time, there are something called inflammatory mutations, like IL-6 activating mutations or IL-6 pathway activating mutations. These are called as inflammatory mutations, and these are supposed to be the most common mutations that are associated with hepatic adenomas. If they ask you second most common will be HNF1 alpha, but the most common mutations causing hepatic adenomas will be IL-6 pathway activating mutations. There is one older name that is generally asked in exams during our time. There are some types of hepatic adenomas called as telangiectatic hepatic adenomas. Telangiectatic hepatic adenomas that are due to this IL-6 pathway activating mutations. Currently, we don't use that name, the telangiectatic hepatic adenomas, but nevertheless, old name for this IL-6 pathway activating mutations are telangiectatic hepatic adenomas, which could be worth remembering in exams. And third one is the beta-catenin pathway mutations, which is not that common, only 5 to 10%. Then finally, we have Sonic Hedgehog mutations, SHH mutations. Usually, beta-catenin mutations typically will be seen in males. And there is a high risk of transformation to hepatocellular cancer because of high degree of ATPI in these patients. So remember why I told you this point is because beta-catenin mutations will cause hepatic adenomas in males. But in general, overall, hepatic adenomas or any benign, hepatic tumors are common in females and not in males. That's why these beta-catenin mutations are very important in the sense that they will be happening in males. And Sonic Hedgehog is the rarest form, SHH mutations, where it will result in obesity and bleeding diathesis, along with hepatic adenomas. So HNF1 alpha, MODY, IL-6 activating mutations usually result in multisystemic inflammatory syndrome along with hepatic adenomas, and beta-catenin pathway mutations will be seen in males. That's the most important point. High risk of malignant transformation compared to others, and SHH will result in obesity and bleeding. And similarly, this IL-6 pathway activating mutations has the maximum bleeding risk usually hepatic adenomas generally has a bleeding risk, but if they ask you maximum bleeding risk among all the types of hepatic adenomas, this IL-6 pathway activating mutations are the maximum risk of bleeding. Then after we know the pathophysiology, etiology and pathophysiology of hepatic adenomas, moving on to origin. Where is the origin? So as far as the hemangiomas are concerned, obviously they are from vasculature, they are from vessels, so that's why they are origin from the mesenchyme. Whereas, of course, FNH is hepatocytes, and hepatic adenomas are also coming from hepatocytes only. Remember, the type of hepatocytes in FNH will be polyclonal in nature, whereas the type of hepatocytes in hepatic adenoma will be monoclonal in nature. That is why these are having high risk of transformation to hepatocellular cancer for sure. That is why the monoclonality is very important. Suppose if they ask you which of the benign tumors exhibit monoclonality, your answer will be, of course, hepatic adenomas. They are the ones which exhibit that characteristic monoclonality. Very, very important point. Because there is an hypothesis in cancers, single cell hypothesis. And this hepatic adenomas, and in fact, even hepatocellular cancers will satisfy that single cell hypothesis. In the sense, they originate from a single cell. So that's why they are monoclonal nature. And if you ask about OCP association, whether they are associated with OCP or not, no. Oral contraceptive pills are not related to development of hemangiomas, but the tumors may enlarge with estrogen or progesterone therapy. They can enlarge in pregnancy, but it is not associated with the origin of the tumor. That's what I'm talking about. But hemangiomas may have response towards estrogen, but they are not responsible for the development of the tumor. In the sense, origin of the tumor is not related to any hormones, but the growth of the tumors may be attributed to the hormones. Like, for example, in pregnancy or in the patient is receiving OCPs, the tumor might enlarge, but it's not related to origin of the tumor. So FNH wise, it is controversial. So we don't know. As far as hepatic adenoma is concerned, OCTs pose a strong risk of development of hepatic adenomas. So strong and definite association with regards to origin of the tumor, at the same time, enlargement and progression of the tumors. Remember, there is a easy way to understand this. After 1960s only, there are a lot of hepatic adenomas that came into limelight, because after 1960s only, there was widespread use of oral contraceptive pills. So that is why we clearly know that OCPs have a very, very strongest association with and definite association with development of hepatic adenomas. Whether they can have malignant transformation or not, so I can write here, malignant transformation or not, definitely no. Hemangiomas are benign tumors. Malignant transformation, no, they do not have any malignant transformation. But hepatic adenomas, as I told you already, definitely have malignant transformation risk, and the highest risk is with the tumors that are going to have that beta-catenin pathway mutation. These have the highest risk of malignant transformation of all, which I've told you already. Maximum bleeding risk with is with inflammatory mutations, that mutations activating IL-6 pathway, and highest malignancy transformation risk is with beta-catenin mutations. Very important. So definite transformation and definite risk of transformation malignancy is there. When you come to the pathology, so usually you will see cavernous spaces. These cavernous vascular spaces, which will be of different sizes, which are lined by these endothelial cells. So these are, this is typical cavernous arrangement. So that is what you're going to see in the pathology, in the biopsy. You don't take a biopsy for hemangioma because it will bleed. But in general, if you do a histopathological examination, this is what you're going to see. These cavernous vascular spaces, which will be of different sizes, lined by these endothelial cells. And as well as, if you think for FNH, focal nodular hyperplasia, it will be like polyclonal hepatocytes that will form nodular appearance, nodules. And along with that, very characteristic feature is that central stellate scar, or simply we can call it as a central scar. Clear? And many of the FNH patients will have very large portal tracts because of the large abnormal feeding vessels. And at the same time, they'll be having abnormal Kupffer cells and sinusoids as well. It look like a normal liver architecture, in the sense there will be no distortion of the architecture. It will be looking like as if the normal architecture, but it will be like more cells in that particular zone. That's what you'll be seeing in a focal nodular hyperplasia, but the architecture will not be distorted. As far as the hepatic adenoma is concerned, there will be sheets of hepatocytes or cords of hepatocytes. That's what we'll see. These are sheets of enlarged hepatocytes. And there will be no central scar. So how to differentiate from FNH? Because here also you'll have enlarged hepatocytes, here also you'll have enlarged hepatocytes, but how will you differentiate? There will be no central scar, number one. And in the sense here, I told you, there will be portal tracts, abnormal Kupffer cells, all these things will be, it's looking like a normal, completely normal liver architecture. But here you will not see any portal tract, no portal triad, and no fibrosis is seen, in the sense there is no central scar, and there will be no Kupffer cells. In the sense, it's just hepatocytes, and hepatocytes in that area. That's all, nothing else. Only hepatocytes. There is nothing else you will see in that particular area. This is truly just hepatocyte mass. That is what we call hepatic adenoma. If you have a normal liver architecture, like appearance, with enlarged hepatocytes, abnormal feeding vessels, and you will see all sinusoids, portal tracts, and the central scar, all these things goes towards a focal nodular hyperplasia. But hepatic adenoma is just a mass of hepatocytes. You don't have sinusoids, you don't have Kupffer cells, you don't have any central scar. Clear? It's an abnormal architecture of liver in that particular place. So what are you going to see in ultrasound? In ultrasound, ultrasound you can easily find out. So usually it will be a well demarcated or well defined mass in ultrasound. It's very clearly seen. At the same time, it will be having a homogeneous appearance and it will be hyperechoic in nature. You'll have a hyperechoic and homogeneous appearance. And this appearance of hemangioma is really, really important. Let us see how it will look like. I think I have a picture of that. Okay. This is a typical appearance of a hemangioma, where you can see this kind of well-defined, like this kind of hyperechoic mass that you're seeing here. So you can see here as well, like a well-defined hyperechoic mass that you see in the ultrasound. That's very, very characteristic of hemangioma. When you take this focal nodular hyperplasia, the appearance is quite variable. They can be homogeneous. They can be hypoechoic to isoechoic. In the sense, like they can, iso means it looks like as if it's a normal surrounding liver, same echogenicity will be there. Hypo means it is less than the intensity of the surrounding liver. So typically it's homogeneous, hypo to isoechoic in nature in ultrasound. And sometimes you might see this central scar, but in ultrasound, picking up the central scar is very rare. Only 20% will be picked up in ultrasound. In reality, 80% will have central scar, but in ultrasound, you will be able to pick up only in 20% of the cases. Traditionally, there is one more question that will be asked in exam. There is one nuclear testing that is used for diagnosing this, like FNH, focal nodular hyperplasia, that is called as technetium 9nm sulfur colloid scan. Sulfur colloid scan. This is a traditional scan. This is a traditional question as well in exam. This is what is used to identify focal nodular hyperplasias. The reason is because this sulfur colloid is something that can be taken up by Kupffer cells. Kupffer cells in that particular area will take up the sulfur colloid, and they'll appear a little bit hot. And apart from this one particular tumor, that is FNH, all other tumors, all other hepatic masses will appear cold in the sulfur colloid scan. Only one tumor that will appear a little bit enhancing or hot in sulfur colloid scan is FNH, because they are taken up by that sulfur colloid is taken up by Kupffer cells. Remember, hepatic adenoma, just sheets of hepatocytes. You don't have Kupffer cells in that area, so they won't take up that sulfur colloid, so they look cold. Similarly, hepatocellular cancer, just sheets of hepatocytes, no Kupffer cells in that area, so they don't take up that sulfur colloid, so they will appear cold. So only one hepatic mass that appears hot or enhancing in sulfur colloid scan is the FNH. So that's why traditionally it is supposed to be a very important investigation for diagnosing FNH. Very important question for exams as well, but not routinely asked nowadays. When you take the hepatic adenomas, there is no actual feature. They might look hyperechoic, and it's not that defined. It may be a little ill-defined, and they may be heterogeneous in nature. Why heterogeneous? Because they have a high risk of bleeding. So most of the hepatic adenomas, they have small bleeds inside within them. So that's why they might be heterogeneous. And remember, in ultrasound, it's very difficult to differentiate from other masses. You need CT scan for that. So, but whatever may be the liver mass, if they ask you the best radiological investigation, always it is contrast CT, triple CT, or I can call as triple phase CCT. We do the scan in 3 phases. One is arterial phase, then is the portal venous phase, and then we call it as something called as a delayed phase, which we'll be discussing in some time. So that's not a problem. Clear? We'll be discussing in detail about that. I'm going to show a lot of images. So what have we seen till now? Incident, then pathology. So what is the local area? What is the thing you will see in that area? Then where is the origin from? And whether it has any association with OCPs or not, whether it has any, whether it has any malignant transformation risk or not, and what is the ultrasound feature, and the CCT feature we'll be discussing in some time. I'm going to have a separate discussion on that. And what is the treatment? Treatment-wise, hemangiomas, generally no treatment required. Please understand, most of the hemangiomas will be left untouched. No surgeon or no other person is going to touch this hemangioma. Suppose if the lesion is going to be very big, like rare, but if the lesion is very big, like more than 5 centimeter lesions, and especially at subcapsular location, there is a risk of bleeding into the peritoneum as well if it's in that location. So if it's subcapsular in location, and if it's a huge hemangioma, like more than 5 centimeter hemangioma, then probably you need a close follow-up. Even that doesn't need surgery. Surgery is needed only if the patient is having refractory pain. If the patient is having severe pain, not tolerable, not responding to your routine management, so then you can probably go for surgery. And most of the time pain will be there if the tumor is in the subcapsular location. That is because of capsular stretch, you will get the pain. Other than that, most of the hemangiomas will be benign, incidentally found out, no problem it will create, and you don't need to treat them at all. More than 5 centimeters subcapsular location, you just need to observe closely, no need of anything else. If it's causing serious pain, then probably you can go for resection, but it's very, 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 very rarely done. And FNH, again, you don't need any treatment at all in the first place. But for hepatic adenomas, definitely you need to proceed with surgery because they have a definite malignant transformation risk. And again, there is a high risk of bleeding. So most of the patients with hepatic adenomas will be taken up for surgical resection. That's all. So there are some indications for observation, in the sense like there are certain hepatic adenomas which can be observed according to the guidelines. So one, females on OCP, plus at the same time, if they are asymptomatic, plus at the same time, if the adenomas are less than 5 centimeter. So these can be managed by stopping OCP. So this can be managed by stopping oral contraceptive pills and following up the patient closely. So close observation is warranted with repeat scans. So whether the size is coming down or not. They're clearly on OCPs, size less than 5 centimeter and the patient is asymptomatic, then in that setting, you can stop OCPs and observe this tumors for quite a while before you move on to the next scan. So serial scans has to be done in that setting. This is the only indication for observation. And even that too is not agreed by all the surgeons. But in general, most of the hepatic adenomas, because of their high bleeding risk and high malignant transformation risk, it's better to take them for surgery as soon as possible. So let me show you the pictures, histological pictures of these. I think I have them. Let us see. These are the histological pictures, by the way. If you see, what you're really seeing here is the first one is the hemangioma. So first one is the hemangioma. So these are nothing but this cavernous vascular space. You can see here, these are the vascular spaces that you're seeing. So these are cavernous vascular spaces along with, which are lined by endothelial cells, and these will be of different sizes, variable sizes. This is typical of hemangioma. And when you take a focal nodular hyperplasia, there will be a focal hepatocyte nodule. This is a central scar that we are talking about. And you generally tend to have this fibrotic areas. Along with that, you will have nodules of hepatocytes, which will have portal triad, which will have Kupffer cells in them. So all these things will be there in the setting of focal nodular hyperplasia. When you take a hepatic adenoma for that matters, there will be no portal triad, no Kupffer cells, no sinusoids. It's just hepatocytes, and hepatocytes. It's cords of hepatocytes, sheets of hepatocytes with absent portal triad, which is very, very classical feature of a hepatic adenoma for that matters. Clear? So we have discussed in detail about the benign tumors. Now let us move on to the CECT characteristics. CECT character, I need to make it smaller, I guess. Yeah. We need to now see the CECT characteristics of different tumors. Let us discuss on that. So typically we call that CECT what we do as triple phase CT, especially for the liver. And liver, especially for liver mass imaging, this triple phase CT or contrast CT is considered to be one of the gold standard investigations. It has 3 phases basically. The first phase is then, in fact, 4 phases is what you can say. One is the non-contrast phase. Then we have the contrast phase. Non-contrast phase, you're going to do routine imaging. You're going to tell whether it is hypo or hyper to the surrounding liver. That's what you're going to tell. In the contrast only, you have 3 phases. What are 3 phases? The first phase is what we called as arterial phase. Arterial phase. And the second phase is what we refer to as a portal venous phase. And the third phase is what we refer to as something called as a delayed phase. Or delayed venous phase, or just a delayed phase. That's what I'm going to tell. So usually non-contrast CT, we take at time 0. In the sense like when you push the patient in, take the CT scan, that is time 0. That's a non-contrast CT. That's where you take. And at the time of 40 seconds after pushing the contrast, you're going to do the arterial phase imaging. And at the time of 80 seconds, double the arterial phase, you're going to do portal venous phase imaging, or simply called as hepatic phase imaging. At around 2 to 5 minutes, you will do another imaging. Another round of imaging will be done. So that is the delayed phase imaging. Clear? So remember, what is the supply to the liver? So this is a question for you. So normal liver parenchyma. Take a normal liver parenchyma. So what is the blood supply? So portal vein is going to supply the blood, or hepatic artery is going to supply the blood predominantly. So what is the blood supply of a normal liver parenchyma? Is it going to be portal venous blood, or if it's going to be hepatic artery blood, which will supply the normal liver parenchyma as maximally? So I think Pranavi has answered already. Answer is portal venous blood. So portal vein is the one that is going to supply maximum blood to the liver parenchyma. 80% of the liver parenchyma is basically supplied to the portal vein only. Only 20% of the liver parenchyma is supplied by hepatic artery. This is very, very important to know. But please understand, all tumors will receive blood mainly from hepatic artery. This is a very, very important point. Clear? All the tumors are going to receive the blood from hepatic artery, but how much blood they are receiving will determine whether it is hypervascular or hypovascular. Please understand, any liver tumor will receive blood from hepatic artery only, but it is the amount of blood that they are receiving from the hepatic artery, even though maximally they receive hepatic artery, but the amount, how much they receive, is what is going to predict whether the tumor will be hypervascular or hypovascular in nature. But nevertheless, leave that, that is not a problem. But two important points to notice: normal liver parenchyma, 80% supplies from the portal vein. When you take any liver tumor, almost all of the liver tumors maximally receive blood from the hepatic artery only. That is the most important point that you need to know. So at the time of injection of contrast, you take a non-contrast CT. At that, after 40 seconds after the injection of contrast, you're going to image the arterial phase. At 80 seconds, you're going to image the portal venous phase. And at 2 to 5 minutes, you're going to image the delayed phase. So this is very, very important. Clear? So now let me show you some pictures, so that it will be easier for you to understand. So what we can show first, maybe I have a pool of images. Let me try to tell what you're going to show. So maybe this is the first one I wanted to show. Second one, third one, fourth one, fifth one, maybe. Yeah, so 5 images I'm going to show. These 5 are very important. Okay, all of them have got inserted. So let us see the first image. You can see a hypoechoic lesion, the non-contrast CT here. What is that? Yeah. So you can see hypoechoic lesion in the non-contrast CT. Then when you see arterial phase imaging, you can see a small amount of contrast that is in the periphery in the arterial phase imaging. Then as you move to the portal venous phase, a little more contrast is coming in. When you go to the delayed phase, it is full of contrast. So what is this tumor? What is this tumor? So let us take the non-contrast phase first, then arterial phase, portal venous phase, and delayed phase. In non-contrast phase, it was having low attenuation in the sense that hypo compared to the surrounding normal event parenchyma. In arterial phase, it is showing a little bit of peripheral spotty enhancement. Then in portal venous phase, it's showing more enhancement. And in delayed venous phase, it produces a complete enhancement. Which is the tumor that shows this characteristic feature? Anyone? You have studied radiology, right? What is the first tumor that we discussed? I mean, by the way, this is just to know whether you guys are there with me or not. What is the first tumor that we discussed? Yes, this is an hemangioma, right? This typically an hemangioma. So that's how they behave. That's why it's the gold standard, triple phase CT. So what really happens is in non-contrast, it will be hypodense. In the sense, we don't call hypodense in non-contrast. We call it as low attenuation. That's what you see. The mass will be of low attenuating mass. Then this kind of spotty peripheral enhancement is called peripheral puddles. puddles of enhancement will be there. Here and there will be spotty enhancement in the periphery. Then in the portal venous phase, that will have more enhancement and move towards the center. And during the delayed venous phase, there will be complete filling of the tumor with contrast. So homogeneous complete enhancement during the delayed phase. So this typically you can tell in one word. That is something called a centripetal filling. That's all. Simple. Centripetal filling. How a centripetal force acts towards the center, like that the enhancement will start from the periphery and move towards the center. Clear? So this is what we refer to as centripetal filling, and this is very characteristic feature of a hemangioma in reality. Then next we have something called a focal nodular hyperplasia. So let us see what will be seen in a FNH. But before that, I think it's arranged in random order. Okay, this is the FNH we are talking about, the focal nodular hyperplasia. When you talk about a focal nodular hyperplasia, like the first thing you need to note is the central scar. In all these things, you can see the central scar. So central scar may look a little different, but in all these things, you can see that central scar which I have shown. And apart from that, what is the characteristic finding that you will see in FNH? So in a non-contrast CT, you're going to see a low attenuation, and it's very visible. You can see a little bit of low density of this mass compared to the surroundings. It's very clear. So you'll see a low attenuation of mass, and the central scar will be more darker. If I remove this, and if you see the central scar will appear more darker compared to the tumor. So tumor itself is of low attenuation, but the central scar will be even more darker compared to the rest of the tumor. That's a very characteristic feature of FNH. And when you come to the arterial phase, in the arterial phase, they will show homogeneous enhancement. And but the problem is the central scar will not enhance here. The central scar will still remain dark, as I've shown you here, but there will be a homogeneous enhancement of the tumor, which you can see very clearly. And when it comes to the portal venous phase, that's the next stage. At 80 seconds, you are going to image. In the portal venous phase, the tumor will be more or less isodense in nature, more or less isodense in nature, in the sense like it's very difficult to differentiate from the surrounding, even though little hypo, but still it's very difficult to differentiate. And in the delayed venous phase, still will be isodense only. It's very difficult to differentiate from the surrounding. Still it will be isodense. But this is the time where the central scar will actually become enhanced. So in the delayed phase, the central scar will be enhanced. Clear? So typically the tumor enhances in the arterial phase, but the central scar enhances the delayed phase. This is very characteristic of FNH. These are the two take-home points I need to know. The tumor except the central scar enhancing in the arterial phase, and the central scar is enhancing in the delayed phase. So these are the 2 points that you need to know about FNH. That's all. So then we have other tumors. Probably like this one is something we can see. There are two tumors here, two masses here. I'll come back to that. So you're going to tell what is that. So number one, in non-contrast, is not given here. Here only arterial and portal venous phase has been given. But in non-contrast, the tumor will be more heterogeneous in nature, because sometimes there can be bleeding within the tumor. So that's why the tumor will appear little heterogeneous. At the same time, in arterial phase, you will see enhancement of the mass in arterial phase. It can be either homogeneous or heterogeneous if there is bleeding inside, but very commonly homogeneous is what you will get in exam. But if there is bleeding within the tumor, you can get a heterogeneous enhancement. And next thing, in the portal venous phase, the tumor will be isodense. And in the delayed venous phase or delayed phase also, the tumor will be isodense. That's what you're typically seeing here. This mass is enhancing in the arterial phase. And again, you can see this enhancing in the arterial phase. But if you really see in the portal venous phase, I don't see really anything here. I couldn't see the mass at all. I couldn't see the lesion at all. So which means it become isodense in the, or isointense in the portal venous phase and delayed phase. So what is this mass? I've given a lot of clues in that. So what do you think is the masses? Yes, of course, I've told you. A lot of clues I've given you already. This is an hepatic adenoma. hepatic adenoma, because I told you the tumor is heterogeneous because of bleeding. So one tumor, if they tell bleeding within the tumor, you have to think about hepatic adenoma. So that's why I told you that heterogeneous point. So non-contrast heterogeneous, that is because of bleeding within the tumor sometimes. So that's what I was trying to tell. So remember, enhancement in arterial phase with isodense or isointense to the surroundings in delayed phase and portal venous phase is typical of an adenoma. So this is how an adenoma looks like. And then we have this one. Okay, these two things. Let us see these two. This is the first one. Let us see what is this. So let me tell you a tumor. This is the most important of all. So in non-contrast phase, what you will see. In arterial phase, what you will see. In portal venous phase, what you will see. And delayed phase, what you will see. Very, very typical. In non-contrast phase, typically they have a low attenuation, which is not shown here, but still the arterial phase is very, very important. Arterial phase, there will be a homogeneous enhancement. The entire mass will enhance. In portal venous phase, they look actually hypo. They will wash out. This is what we called as an early washout, which means they will enhance initially, but as if they have incontinence of the contrast, they will lose the contrast as soon as it gets enhanced. So at 40 seconds, they will have a homogeneous enhancement. As soon as they enhance with the same speed, they will lose the contrast. This is called as early contrast washout. This is called contrast incontinence by some radiologists. But nevertheless, this is a very, very important feature of one important cancer. So what is that? Yes, of course. This is hepatocellular cancer. This is HCC. Very, very important point. So what you're really seeing here is a arterial phase enhancement, typical arterial phase enhancement with the incontinence of the contrast during the venous phase. In portal venous phase, it is completely losing the contrast. So this kind of hypodense lesions in the portal venous and delayed venous phase is very, very typical and classical of a hepatocellular cancer. Very important classic point. And that is very important because you have to differentiate from hepatic adenoma, which might have malignant transformation towards HCC. That's why you need to know hepatic adenomas during the portal venous and delayed venous phase. You will have basically an isodense lesion. But if it's a hepatic adenoma, typically you will be having a hypodense lesion or a hypointense lesion. Okay, this is also a very important tumor. So this is a final tumor that we are going to discuss here. So here, the tumor in non-contrast CT typically will have low attenuation. Remember, most of the tumors in non-contrast CT will have low attenuation. That's why, we don't mind that much. It's not that important. And second, in arterial phase, it's going to have homogeneous enhance. Not homogeneous, but it can look a little different. They might enhance a little bit, but typically they'll be in arterial phase also hypo or iso. They don't enhance that much. There might be little peripheral enhancement, but not that much. They'll be hypo or iso only. And in venous phase, there'll be no change. Once again, they'll be looking hypo or iso only in venous phase. Remember, there will be no change in the arterial and the venous phase. That's very, very important here. Because otherwise, you might be asking how to differentiate from hemangioma. That's why that point is important. And delayed phase, this tumor will show a typical enhancement in the delayed phase. Delayed phase enhancement. So whenever they give a tumor that is having a delayed phase enhancement, so what is this tumor? So the same thing is applicable here. So there's no enhancement here, no enhancement. Suddenly it enhances during the delayed phase. So what is this tumor? What is this cancer, to be honest? Delayed phase. Which means there is no change between arterial and venous phase. But suddenly, yes, correct. Suddenly in the delayed phase, it enhances. This is an intrahepatic cholangiocarcinoma. Correct. Only Ankit has answered correctly. Intrahepatic cholangiocarcinoma. Or simply we can call it as cholangiocarcinoma. That's all. So this is typical finding of a cholangiocarcinoma. Usually in exam, when you get this kind of images, and the patient has history of ulcerative colitis, think about this. Because they don't give directly. Most of the time they'll give history of ulcerative colitis. Then they might give this kind of history. Or probably they can give a history of primary sclerosing cholangitis, PSC, and then they will give this kind of images. So whenever because these increase the risk of development of cholangiocarcinoma. That's why they don't ask direct questions in exam mostly. That's why these images are very important. Remember, you can ask in hemangioma also there will be delayed phase enhancement, But remember, in hemangioma, you will see that slowly encroaching enhancement, that centripetal enhancement, slow filling from the periphery, like puddles of water starting to get filled towards the center. So that's how you will see in hemangioma. But in cholangiocarcinoma, there won't be any much difference between arterial and portal venous phase. Suddenly in peripheral, delayed phase, there will be all of a sudden there will be blooming enhancement. That is very characteristic feature of a cholangiocarcinoma. So these are the important tumors that you need to know for exams, especially the CCT is very important for liver masses. So that's why they will ask, out of all these things, if they ask you, single most important thing that you need to remember, that is hepatocellular cancer. That is the single most important thing that you need to remember. There will be hypodense lesion in non-contrast CT. And at the same time, these patients will have arterial phase enhancement, that will be homogeneous enhancement. And suddenly there will be contrast incontinence resulting in wasting of contrast or loss of contrast or washing out of contrast. That's called early washout in the portal venous phase and delayed phase. So this is very, very important characteristic feature of a hepatocellular cancer. Hemangioma, very simple. It's centripetal filling, slow filling from the periphery, from the arterial phase till the delayed phase. And next, we are going to the important discussion on hepatocellular cancer. This is the hero of our discussion for the day because there are a lot of questions on hepatocellular cancer. Epidemiology wise, hepatocellular cancer is more common in males. Please understand, hepatic adenomas are common in females and associated with OCPUs, but hepatocellular cancer is more common in males compared to that of females. We'll discuss on that why. So compared to that of females. So usually age more than 40 to 50 has a high risk of development of hepatocellular cancer, especially age more than 50. The more the age is, more is the risk of developing hepatocellular cancer. And etiology wise, so when you talk about etiology of hepatocellular cancer, only one etiology you need to remember, like how they tell for rheumatic heart disease, the only etiology to remember, for mitral stenosis, only etiology you need to remember is rheumatic heart disease. So my professor used to tell, so MS means first etiology rheumatic heart disease, second etiology rheumatic heart disease, third etiology is rheumatic heart disease. Similarly, when you talk about cirrhosis, when you talk about HCC, the first etiology must be cirrhosis, second etiology must be cirrhosis, and third etiology also must be cirrhosis. Any patient with cirrhosis has a risk of developing hepatocellular cancer. Remember, 80% of the case of hepatocellular cancer will be developing from underlying cirrhosis only. Cirrhosis is the most common cause and the most important cause of development of hepatocellular cancer. Apart from cirrhosis, there are some risk factors which are independent of cirrhosis which can cause hepatocellular cancer. Like for example, chronic HBV and HCV infection. This is something we have discussed already in the hepatitis B and hepatitis C section. So no need to worry much about that. HBV and HCV has an independent risk factor for development of HCC apart from cirrhosis. They can also cause cirrhosis, but apart from cirrhosis, they independently has risk of development of hepatocellular cancer. In that, they will be asking you what is the reason for development of hepatocellular cancer in HBV. Remember, two reasons are there. One, because of chronic inflammation caused by hepatitis B virus is one of the most important reasons of development of HCC. Second reason, even without inflammation or even without cirrhosis, HBV can induce development of hepatocellular cancer because of insertional mutagenesis. This is something we have discussed already in the hepatitis B section itself. There's something called insertional mutagenesis when the virus tries to insert itself into the genome of the particular cell. That time there will be error-prone insertions because these are very error-prone repairs that will happen. So that might result in loss of some DNA repair genes resulting in the development of hepatocellular cancer. So that's called insertional mutagenesis. So they can induce HCC through inflammation and production of cirrhosis, or independent of inflammation and cirrhosis, they can produce hepatocellular cancer by something called as insertional mutagenesis. And third reason is the X gene. You would have studied in HBV genome, that is open reading frames. There is something called ORFX. X, the function is unknown, but we believe that it is going to result in the development of hepatocellular cancer, probably. Third, NASH is associated with, these are independent risk factors. Let me put cirrhosis separately, then independent risk factors apart from cirrhosis. NASH can produce some risk factor for development of cirrhosis, and hemochromatosis or any iron overload in the liver. Hemochromatosis, or you can think about iron overload in the liver, can result in development of HCC. Iron overload in the sense, this includes porphyrias as well. Remember, any condition that produces iron overload has a risk of development of HCC, including porphyrias. Number 5, Wilson disease, of course. as a risk of developing HCC, and alpha and antitrypsin deficiency. We know I already mentioned that as a risk factor development of HCC. Then schistosomiasis as a risk factor for development of HCC. Then we have glycogen storage disorders. Certain disorders have risk factor for development of HCC. Then aflatoxin. Okay. Chronic ingestion, not acute ingestion, chronic ingestion of aflatoxin is associated with development of hepatocellular cancer. Because aflatoxin induces, because this is a question in old AIMS exam, like maybe in 2009 or 10, they asked, this could be pathology or probably even a SPM question. Aflatoxin induces a mutation, usually in codon 259 of TP53, P53 genome and P53 gene. It induces a mutation. There will be a GC to TA mutation, which means the GC that should be the original will be transformed to TA. So this is the mutation that is typically related with aflatoxin-induced hepatocellular cancer. So codon 259 of TP53 gene, GC will be mutated to TA. So that is the reason for development of hepatocellular cancer. And tobacco and alcohol, smoking and alcohol, independent risk factors for development of hepatocellular cancer. Clear? So in that, smoking has a very low association. Alcohol is the most important association. Smoking has very, very little association. Remember, smoking is related to every single cancer in the body except two cancers. One is your primary brain cancer. Brain tumor is not associated with smoking. Second is your liver cancer. Liver cancer has a very low risk. Only very few epidemiologic studies have told, but apart from that, smoking has a very, very low risk of developing hepatocellular cancer. Apart from these two cancers, smoking has relationship with every single cancer. Pancreas, stomach, esophagus, wherever you take, smoking has a relationship. So some etiological association. So these are the factors that are independent risk factors for development of hepatocellular cancer apart from cirrhosis. But the single most important risk factor for development of HCC is cirrhosis, and cirrhosis, where 80% of the case of HCC will be due to cirrhosis only, without a doubt. There is absolutely no doubt about that. And when you come to the clinical features, most of the patients will be asymptomatic. If they become symptomatic, means like it's advanced stage. Usually, if they develop symptoms, it means the patient is having advanced stage of disease. That's all. Most of them will be asymptomatic. That is the reason why monitoring is very important, especially when a patient goes for cirrhosis or when you're making a diagnosis of cirrhosis, you need to monitor these patients for HCC. When you have a chronic HP or HCV, definitely you have to monitor for HCC. Even if the patient is having normal ALT, AST, doesn't matter. If the patient is chronic hepatitis B virus or hepatitis C virus, you need to monitor for HCC with 3 to 6 monthly alpha fetoprotein and ultrasound if possible. That's why this is very, very important. So you cannot pick up in early stages. Most of the disease will be asymptomatic. Most of the HCCs will be asymptomatic. If they produce symptoms, usually they'll be very advanced. And what could be the symptoms? The most common symptom if they ask you is right upper quadrant pain. Right upper quadrant pain is going to be the most common, where the tumor might start infiltrating the capsule and stretching the capsule, but it's really very rare. Then followed by weight loss, which is very rare. And at the same time, they can develop fever. And again, we don't know the reason for development of fever, but most cancers do produce fever, and this also produces fever. But please understand, jaundice is a very, very uncommon finding in hepatocellular cancer. The patient might develop jaundice due to underlying cirrhosis, due to decompensation, but development of jaundice due to HCC is very, very rare. They don't produce jaundice. Very, very uncommon finding. So most common if they ask you is RQ pain. That is right upper quadrant pain only. But remember, symptoms itself indicates an advanced disease. Very rare to have a symptom in the early stage disease. So there are 2 points that you need to know, okay, which I'll tell you with regards to the clinical management. With regard to the clinical diagnosis of hepatocellular cancer. A patient who's a known cirrhosis develop HCC, there is a high chance of decompensation. They might go for decompensated liver disease, which means previously it was a compensated cirrhosis. Suddenly, if they develop HCC, there is a chance of becoming decompensated. So decompensation is possible, which means what I'm trying to tell is, this is a very important point. HCC by default or HCC de novo does not produce jaundice, but HCC along with cirrhosis can produce decompensation. Because of that, the jaundice might worsen. So there's a 2 things that you need to know. HCC de novo will not cause jaundice, but because they produce decompensation, they might result in development of jaundice. That's fine. So HCC might result in decompensation. But second is the most important point. A patient who's a known cirrhosis plus they have developed decompensation and you are working up this patient. So while working up, you are finding out the patient is having a portal vein thrombosis or probably hepatic artery thrombosis. Portal vein thrombosis or a hepatic artery thrombosis. What will you suspect? What is the probable cause? A patient is a known case of cirrhosis, develops decompensation. I'm talking about ascites and varicose bleed. Ascites and varicose bleed. Yes, develops a portal vein thrombosis or a hepatic artery thrombosis. Very simple. Here, you're talking about HCC only. The next possible thing you need to look out for is HCC. Why? Because of the venous or arterial invasion, vascular invasion by the cancer. So that's why a patient is already a known cirrhosis, developing decompensation, and working up, you have found out the patient is having a hepatic arterial portal vein thrombosis. If this is the clue in exam, it's always almost due to HCC because cirrhosis has caused HCC. So this is something which is very important to know. So that's why I told you a patient who's a known cirrhosis, developing decompensation as multiple etiologies. So final nutshell, what I want to tell is patient who's a known cirrhosis, developing decompensation. In the sense previously it is a common cirrhosis, developing decompensation. The reasons are multiple. In the sense like there's not only one reason, multiple reasons are there. Multiple etiologies. One of the etiology is HCC. That's all. HCC. And one of the etiology is hepatic artery or portal vein thrombosis. This is very rare basically. And whenever you think about hepatic artery or portal vein thrombosis, you are going to think about HCC only, nothing else. Because the next step you need to do is ruling out a hepatocellular cancer. And these are the points that you need to know. It might look a little confusing, but still very important points. So known cirrhosis, developing decompensation, multiple etiological factors are there. One of the etiology, of course, is HCC. One of the etiologies, of course, hepatic arterial portal vein thrombosis. But the moment you diagnose hepatic arterial portal vein thrombosis, you need to think about hepatocellular cancer as a very important possibility if the patient is having a cirrhosis. These are some of the clinical pearls that you need to know. So in exam, you might be given a case of cirrhosis who's developing decompensation due to hepatic artery or portal vein thrombosis. They will ask you what is the next thing you have to suspect. Answer is always hepatic artery or portal vein thrombosis because of vascular invasion. And there are some paraneoplastic syndromes that can happen with hepatocellular cancer. So what are the paraneoplastic syndromes, PNS, that can happen with hepatocellular cancer? The first one is hypoglycemia, of course, because liver, is the source of gluconeogenesis, glycogenesis, and so many things. If the liver is not functioning properly, you can think about development of hypoglycemia. That's an easy one. Usually this hypoglycemia will be mild and asymptomatic, but they will be having hypoglycemia usually. That is due to declining gluconeogenesis in the liver. But there are many hepatologists who contradict the statement. They are telling that hypoglycemia is not due to HCC itself, but many patients with cirrhosis itself will have hypoglycemia because of the poor functioning of the liver, not just because of HCC. That is because of advanced cirrhosis itself, they can develop hypoglycemia. Then they can develop erythrocytosis. That is due to erythropoietin secretion. They can develop polycythemia due to erythropoietin secretion by the tumor cells. And they can develop hypercalcemia. That is due to PTH-related peptide production. Remember, the most common cause of hypercalcemia due to malignancy is due to PTH-related peptide production. Second most common cause of hypercalcemia due to malignancy is osteolytic metastasis. We discussed that already. Very rarely it can be osteolytic metastasis, but this is very rare. Any tumor producing hypercalcemia, most common mechanism is PTH-related peptide only. And next, they can develop diarrhea. That is due to production of VIP, that is vas-active intestinal peptide, or probably gastrin, which is very rare as well. And they can develop dysfibrinogenemia. In the sense, I'm not talking about low fibrinogen or high fibrinogen. It can be either, that is dysfibrinogenemia. Patients may have increased thyroid binding globulin, and patients can develop PCT, that is porphyria cutanea tarda. And there are some cutaneous signs that you can develop with hepatocellular cancer. One is dermatomyositis. which I've discussed already in rheumatology. Cancers can result in dermatomyositis. Then sign of lesser trelad. I'll show you what that is called, multiple seborrheic keratosis. That's called sign of lesser trelad. And we have something called pemphigus foliaceus. Pemphigus foliaceus. So let us see that sign of lesser trelad is something they will surely ask in exam. This is what we refer to as sign of lesser trelad, in the sense like this is what we called as multiple seborrheic keratosis. Same image you might get in exam. Clear? Sign of lesser trelad. LESERTRELAT. Sign of lesser trelad, multiple seborrheic keratosis. It can be caused by many cancers. One of the important cancers is hepatocellular cancer. And remember, extrahepatic metastasis is very, very rare. Intrahepatic metastases are very common, but extrahepatic, the extension of the tumor outside the liver, is very, very rare. Usually we don't get. And what are the risk factors for metastasis? Usually metastasis is very rare. Risk factor metastasis includes size more than 5 centimeter, very large tumor, or if there is a vascular invasion, especially large vessel invasion like portal vein or hepatic artery. If there is a large vessel invasion, vascular invasion, then these are the areas where you might expect a metastasis, but in general, metastasis is very, very, very rare if it's a primary hepatocellular cancer. And the most common site for development of metastasis is the lungs, then followed by abdominal lymph nodes, then followed by bone, then followed by adrenal glands. So this is the order of metastasis, but if they ask you the most common location of this hepatocellular cancer related metastasis is the lungs, single most important area. But remember, metastasis is generally very, very rare. You don't have a tumor extension outside the liver in most of the cases. And as far as the investigations are concerned, monitoring is the key. So that is why one of the first investigations that you need to know is alpha fetoprotein, very commonly used as a screening test for high-risk patients with with cirrhosis to detect the development of hepatocellular cancer. Normal alpha fetoprotein is somewhere around 10 to 60, I guess. Yeah, 10, not 10 to 60, 10 to 20. 10 to 20 nanograms per ml, I guess. Yeah. Normal alpha fetoprotein is 10 to 20. And sensitivity of alpha fetoprotein is only 60%. Specificity is a little high, around 80%, to suggest hepatocellular cancer. But remember, which means 40% of HCCs may have a normal alpha fetoprotein. So please understand this. 40% of HCCs may have a normal alpha fetoprotein, which means the sensitivity is very poor. So which means you will be missing out on 40% of HCC, especially small hepatocellular cancer. Remember, the production of alpha fetoprotein will depend on the size of the tumor. More the size of the tumor, more is the sensitivity of alpha fetoprotein. But lesser the size of the tumor, less is the sensitivity of alpha fetoprotein. Very small tumors, like less than 1 centimeter especially, may have a normal alpha fetoprotein, and you might basically miss out on the tumors. Clear? So that's why you need to be very careful. Alpha fetoprotein is not very sensitive. Then we have some microRNAs which can be used. MicroRNAs, but not yet validated, which can be used as markers. And there are some new markers like des gamma, carboxy, prothrombin. This is a new marker, not yet validated, but supposed to be more effective compared to the alpha fetoprotein. Then there is something called AFP-L3. So this is a different form of ALP that's called lens cluneraris agglutinative reactive ALP. That's called AFP-L3, which is also not yet validated. And then we have something called a glypican-3. This is a cell surface heparan sulfate proteoglycan, which of course heparan sulfate means proteoglycan only. So this is a cell surface proteoglycan, so glypican-3, which is upcoming. Many of the trials are using this glypican-3, but nevertheless still we are stuck on to alpha fetoprotein because of the cost. At the same time, these are not validated yet to use in clinical practice. But among all this, glypican-3 is one of the very good candidates for the future. So for detecting hepatocellular cancer. So then we know the imaging. So there are two basic imaging modalities. One is the ultrasound, and of course, second one is the CECT, that is triple phase CT. So remember, ultrasound, there are some factors which favor HCC. Number one, irregular borders. Of course, any cancer will have irregular borders. Then presence of something called as halo sign. And if the mass shows something called vascular invasion. It's straightforward. Remember, it's very difficult to see. I mean, in the sense, it's not rare, but rarely seen in ultrasound. Ultrasound will not pick up this vascular invasion that easily. So, but still, if you are able to pick up this vascular invasion, these factors will tell you there is a high chance of development. I mean, high chance that the mass is basically a hepatocellular cancer. And we know what is CECT finding. Non-contrast phase, typically you will be having low attenuation, hypo, and arterial phase, there will be a homogeneous enhancement. And in portal venous phase and delayed phase, there will be a washout of contrast, which means they will be once again hypo. Here there will be homogeneous enhancement, which means here there will be hyper. And there will be a incontinence of the contrast or early washout resulting in hypotension in the portal venous and delayed phase. So this is very typical of a HCC. But please understand, that is why whenever you are monitoring, you monitor with AFP along with ultrasound. Usually we do monitoring with these two, because when you combine these two, the sensitivity will be usually more than 80 to 90%. So little bit higher sensitivity when you are combining these two. So that is why you combine alpha fetoprotein ultrasound. If you use only alpha fetoprotein or use only ultrasound, the sensitivity is not that great. Ultrasound should always be done along with alpha fetoprotein if the patient is at high risk. For example, a patient is having cirrhosis, cirrhotic liver, multiple cirrhotic nodules are there. Ultrasound shows 1.1 centimeter mass lesion in the caudate lobe of the liver. Along with that, your alpha fetoprotein levels are normal. So what do you next? What's your diagnosis and what are you going to do next? What is the diagnosis and what are you going to do next? Anyone who's awake and wants to tell the answer? So what are you going to do next? Yes, actually next step is I will be taking a biopsy, basically. I mean, or alternatively, I can do a CECT and then proceed with biopsy, but ideally it's just to be biopsy, because there is a very, very high chance of HCC, extremely high chance of HCC, because patient is having a background of cirrhosis, a new mass lesion. Because it's very small in size, the AFE may be normal. So if you want, you can proceed with CECT and then for a biopsy. But in general, I tend to biopsy this lesion. This I will take it as HCC unless proved otherwise. That's all. So as far as the ultrasound is concerned and CCT is concerned, we have something called a LIRADS system, like how you have BIRADS for breast cancer and CORADS for COVID patients. We have something called LIRADS. So in that we have similarly LRNC. So liver radiology NC. So what do you mean by NC? NC means non-categorizable, which means images are not sufficient to make a diagnosis. So in this setting, you have to repeat the imaging with an alternative modality probably after 3 months. So you have to follow up this case. And then we have LR1, LR2, LR3, LR4, LRM, LR5, LRM, and we have something called LRTIV. So these are the nomenclatures that's been proposed. So 1 and 5 are the extremes. Remember, 1 is definitely a benign lesion, which means you're diagnosing probably hemangioma with typical features. That will come under LR1. And LR5 is definite hepatocellular cancer, without a doubt. It shows all the features, characteristic features. When you talk about the characteristic features, so we have 2 out of 3. 2 out of 3 characteristic features, if it's there, that is supposed to be a typical HCC. So what are the characteristic features? So there will be a typical washout pattern, which I've told you already, that early washout. Along with that, there will be enhancing capsule, and you're demonstrating growth of this tumor. So for example, if you decide to follow up the mass, if the mass grows by more than 50% in less than 6 months, the mass grows by more than 50% in less than 6 months. So that is also one of the important features. Among these 3, the typical enhancement and washout pattern, along with enhancing capsule, and if you demonstrate the growth, if among these 3, if you demonstrate at least 2 out of these 3, it is LR5. It's definite HCC. That's all. In the sense, even if you don't demonstrate the growth, if you have a typical washout and enhancing capsule, that itself will tell you it's an HCC. So that is LIRADS 5. That's typical. Almost all the phase of HCC will be there, LR5. LR1 on the other hand is typically benign. You are very confidently telling that's a hemangioma. So LR2 we can call it as probably benign, and LR4 we can call it as probably malignant. In a sense, we don't have all the typical characteristic features, like for LR4. In the sense, probably they might be having only 1 out of 3. So in that sense, you can probably tell it's an HCC, probably malignant, probably HCC, but it's not definitely HCC. So probably benign in the sense you have a hemangioma, but not with very typical features. So they might have some atypical features. That is what we call LR2, but still you are sure it's a hemangioma. That is LR2, probably benign. And LR3 is probably intermediate probability for malignancy. So you are seeing some atypical nodules, dysplastic nodules in a cirrhotic liver. In cirrhotic liver, which means nodules in a cirrhotic liver is quite common. But in that, you are seeing a different kind of a nodule, like a mass kind of an appearance, but you don't know whether it's a nodule or a mass. So this is what we call it as an indeterminate appearance or an intermediate appearance. So probably benign, and LR1, LR2, no need to do anything. No need of any further imaging. You're just going to do routine HCC surveillance if the patient is at a high risk. And LR5, typically you don't need biopsy. Start treatment straight away because it shows all characteristic features of hepatocellular cancer. Clear? So straight away you can start with treatment. There's no need for biopsy. LR4 is the area where you need a biopsy typically because you are telling it's probably malignant, not definitely malignant. And LR3, you don't know. You have to repeat imaging because it's indeterminate. You have to repeat imaging in 3 to 6 months. That you're doing. So whether to see that mass is enlarging or not, probably the washout pattern will be much clearly seen after 3 to 6 months. So you have to repeat imaging in 3 to 6 months. So then we have this LRM. So what do you mean by LRM? LRM is definitely malignant lesion, which means M stands for malignant lesion, but it is HCC or not, we don't know. So it might be a cholangiocarcinoma also. It's a malignant lesion, but it could be HCC or it could be other tumor also, like probably a cholangiocarcinoma. We don't know. So LRTIV means tumor in vein. Tumor in vein. So that is what we called as TIV. So what do you mean by tumor in vein? Which means you have a portal vein. Inside that you are seeing a soft tissue lesion. Inside that you are seeing a soft tissue lesion or enhancing soft tissue lesion inside the portal vein. So this is what we called as LRTIV, tumor in vein. This is LIRADS. So LRNC, non-categorizable lesion, you're going to repeat imaging with a different modality or with the same modality after 3 months. LR1 and LR5 are clear cut. LR1 definitely benign, LR5 definitely HCC with all characteristic features. LR5, no need to do anything, straight away start treatment is HCC, no need of any biopsy. LR2 and LR4, it's probably benign or probably malignant. So LR2 is probably benign, and LR1 and LR2 you don't need no need to do anything. LR4, it's probably HCC, so you might be needing a biopsy. LR3 is indeterminate, so you have to repeat imaging after 3 to 6 months. LRM, definitely malignant, but you don't know what malignancy it is. It could be cholangiocarcinoma. LRTIV is tumor in vein, so you have to biopsy the lesion in that setting because many tumors can invade the veins, so it doesn't matter. So what are the criteria to tell definite HCC? So we are talking about LR5. I told you the characteristic features. So let me tell you when you will tell it's LR5. So there are 2 criteria. One, if the tumor is having size more than 2 centimeter, plus the patient is having arterial phase enhancement, plus just 1 out of the 3 characteristic features are more than enough. 1 out of the characteristic features are more than enough. Clear? So the tumor is more than 2 centimeter, plus typically they are enhancing in the arterial phase, which I've showed you already, plus even 1 of the 3 characteristic features which I've told you, like enhancing capsule or typical washout. So any one if you demonstrate, that is LR5, it's an HCC. Or second thing is size 1 to 2 centimeter, plus they are showing arterial phase enhancement. But in this setting, because the size is a little less, you need at least 2 out of 3 of the characteristic features which I have discussed. So this is the criteria to say that the patient is having LR5. So according to radiologist. So size more than 2 plus arterial phase enhancement, just 1 out of 3 characteristic features. I told you what are the 3 characteristic features. Enhancing capsule, typical washout pattern, and third one is the growth demonstration, which is more than 50% less than 6 months. So the size is less than 2 centimeter, that is 1 to 2 centimeter, with typical arterial phase enhancement. Plus, if you have at least one of the three characteristics which I mentioned, then again you can take it as HCC unless proved otherwise, and you can start the treatment straight away for LR4. You don't need any biopsy in this setting. That's what is very, very important. So then apart from that, one more important thing is to differentiate. Yeah, this is what I'm talking about. So differentiate between HCC and a fibrolamellar HCC. So routine HCC that you're talking about, and there is something called a fibrolamellar variant of HCC. And I don't know, this is very rare. I am not very interested in fibrolamellar type of HCC, but your examiners do ask this question. So when you take a male-female ratio, as I told you, it's approximately 3:1, which means HCC is common in males. But when you take fibrolamellar HCC, the ratio is 1:1. There's no male-female difference. And the age of the patient, median age is approximately 55 years in HCC, whereas 25 years in the setting of fibrolamellar. It means the patients will be more younger compared to the routine HCC in fibrolamellar variant. And nature of the tumor is invasive, especially vasculo-invasive, whereas fibrolamellar variant will be more circumscribed in nature compared to the original HCC. And as far as the lobar involvement is concerned, the right lobe will be more involved than the left lobe. In the sense, first, most common is the right lobe, then followed by both lobes, then followed by left lobes. Even if you take the example which we have shown in the imaging, if you go back and see the example, you can see that it is in the right lobe predominantly. So that's why it's very important. Right lobe is the one that is more commonly going to harbor a hepatocellular cancer. So whereas fibrolamellar type will be more commonly in the left lobe compared to the right lobe. So resectability, whether we can resect these tumors or not. Resectability, because it's more circumscribed, resectability is more. Because it's not circumscribed, it's more invasive in nature, it's less resectable. Less than 20% of the tumors will be resectable. And as far as spread is concerned, spread is predominantly blood. I told you this is vasculo-invasive, hepatic artery portal vein, that's the usual route of spread. But here it is more of a lymphatic spread, lymph nodes. And association with cirrhosis. I told you 80 to 90% of the cases of HCC are due to background cirrhosis only, whereas only 5% of the fibrolamellar type of HCC will be having background cirrhosis. Very rare association with cirrhosis. And tumor marker. Tumor marker is alpha-fetoprotein here and neurotensin here. So the important point note that's commonly asked in exam is normal AFP. So fibrolamellar variant will have a normal alpha-fetoprotein. And HBV and HCV association is very, very common. You don't have any association here. And prognosis-wise, HCC itself has a poor prognosis. Why? Because most of the patients, number one, HCC is more invasive, as I told you. At the same time, there will be background cirrhosis in most of the patients. That itself portends a poor prognosis. Or there is one organ that is failed, that is liver. So they're going to have a poor prognosis. But whereas in fibrolamellar type, it is good prognosis, reasonably good prognosis, average to good. And if you take the pathology, fibrolamellar type will show this kind of fibrous bands. All these things would have talked in pathology. There will be fibrous bands or lamelline cut section, and 40 to 50, 50% you can take, but 40 to 70% may have a central scar similar to that of focal nodular hyperplasia. But if they ask you how to differentiate fibrolamellar type of HCC from focal nodular hyperplasia, remember that technetium 9M sulfur colloid scan is there. That will typically show uptake in the setting of FNH, but it will not show any uptake in the setting of fibrolamellar HCC, because HCC means they don't have any Kupffer cells, but FNH will have Kupffer cells. But remember, these fibrolamellar type of HCC also may have central scar similar to that of what you see in focal nodular hyperplasia. This is the difference between traditional HCC and fibrolamellar type of HCC. And then we have something called molecular classification of HCC, like how we saw the molecular classification of hepatic adenoma. I told you 4 types, isn't it? In that, the inflammatory type, IL-6 activating pathway mutations have the highest risk of development of bleeding. And similarly, the beta-catenin mutations are the ones that are going to have a highest risk of malignant transformation. And apart from that, I told you SHH, and apart from that, I told you HNF1 alpha just Moody. So 4 molecular classes I told you. Similarly, here we have some molecular classifications. The first pattern is cholestatic and well-differentiated HCC. So they'll produce a cholestatic pattern and well-differentiated type of HCC. Typically, the mutation associated with something called a CTNNB1. This is the mutation that is associated. Second type is poorly differentiated and highly proliferative HCC. High K67 index. So typically associated TP53 mutations. Remember, for example, you can remember this aflatoxin-related HCC. Very poorly differentiated because of TP53 mutations. And we have something called a serous hepatocellular cancer, serous HCC, which will be due to mutation of this tuberous sclerosis genes, TSC1 and TSC2 genes. Then fourth type, we have something called a steatohepatic type of HCC. Steatohepatic type of HCC typically will be due to IL-6 and JAK-STAT activation. IL-6 and JAK-STAT activation. So these are the four types of HCC based on molecular classification. And of course, the most common will be this cholestatic and well-differentiated type, which is due to CTNNB1 type. So this is the usual commonest form. And please understand, if they ask you about LFTs, suppose if they ask you about LFTs, what pattern you will see? Option is yours. You're going to answer whether it's a hepatocellular pattern or it's a cholestatic pattern. What you will see in a patient with a HCC? If they develop HCC, what pattern you will see? Hepatocellular pattern or a cholestatic pattern? LFT in a patient with HCC. Of course, LFT will be determined by the underlying cirrhosis. That is different. But cholestatic pattern is the commonest one. Any mass lesion in the liver, which we have discussed already, will produce cholestatic pattern. We have told you multiple times. There's no doubt about that. So there's no need to unnecessarily break your head on that. We have discussed already. Any mass lesion, including metastasis, a breast cancer patient having a cholestatic pattern. So they won't give direct questions. Please understand. So breast cancer patient developing a cholestatic LFT is metastasis. There's no doubt about this. It's a liver mets. That's all. A colon cancer patient developing a cholestatic LFT is a metastasis. That's all. Any mass lesion in the liver will produce a cholestatic type of liver enzyme elevation only. Will not produce or rarely produces this hepatocellular pattern of liver enzyme elevation. So this is something that's very important. And if they ask you the most sensitive marker for HCC with any level of differentiation, if they ask you, it is arginase 1. Arginase 1. Arginase 1 is supposed to be the most sensitive marker for HCC of any level of differentiation, basically. So glupican 3 is very important for poorly differentiated tumors. Previously, we studied certain markers. Glupican 3 is for poorly differentiated tumors, but for all levels of differentiation, arginase 1 is very, very important. So there are certain new markers which you need to know. In that, I need you to remember only two things. One is arginase 1, which is most sensitive for any level of differentiation. And second one is glupican 3, which is more selective and specific for poorly differentiated tumors. So let me discuss whatever I told you till now with regards to HCC. So number one is males, older age, risk factor cirrhosis. Apart from the HBV, HCC, and a lot of other risk factors, including porphyrias. And symptoms, usually no. It should be detected by monitoring. If at all they produce symptoms, REQ pain is the most common symptom. Jaundice is very rare. And portal venous invasion and hepatic artery invasion is quite common. And they can result in development of varicose bleed and sudden decompensation in patient cirrhosis. And PNS hypoglycemia is very important. Apart from that, the sign of lesser teloid is a multiple times asked question. And investigation is alpha-fetoprotein and ultrasound has to be performed usually together for screening purpose in high-risk patients. But alpha-fetoprotein is poorly sensitive, only 60%. If you include ultrasound together, sensitivity increases to 80 to 90%. The more the size of the tumor, the more the sensitivity of alpha-fetoprotein. Ultrasound, irregular borders, halo sign, and vascular invasion, very characteristic, but all the features may or may not be seen. On the other hand, any mass lesion in a cirrhotic liver has to be followed up or be followed up with a CCT, or it has to be biopsied to prove it's a hepatocellular cancer. Based on LIRADS, the only thing they will be asking you is the LIRADS 5 typical HCC pattern, which is size more than 2 centimeter plus arterial phase enhancement plus one of the three characteristic features. The three categories which we have discussed is typical washout, capsule enhancement, and growth demonstration, more than 50% in 6 months. And second is size 1 to 2 centimeter plus arterial phase enhancement plus at least 2 of the 3 categories which is discussed. And difference between HCC and fibrolamellar type: more fibrosis, normal AFP, less invasive, more circumscribed, easily resectable, better prognosis with fibrolamellar type of HCC. They may have a central scar. And molecular classification is CTN and B1, very, very important. Cholestatic pattern in left, usually common. And most sensitive for all level of differentiation, arginase-1. And for poorly differentiated and highly proliferated cancers, usually associated with TP53 mutations. And most important marker in this setting is Glypican-3. Okay. These are the points that you need to know as of now. Then we are going to the management, which is again a very important thing with regards to hepatocellular cancer. As far as the management is concerned, we have a different scoring systems are there. We have the AJCC TNM staging. Then we have something called Okuda staging system. Then we have something called a CLIP score. Then we have ALBI score. Then we have something called BCLC, Barcelona Clinic Liver Cancer Staging System, BCLC. In that, currently for treatment purpose, we follow the BCLC only because it integrates a lot of things. It integrates a lot of things into it. So that's why we use BCLC. But nevertheless, let us see one by one. So what is ALBI? ALBI is albumin and bilirubin. Only 2 parameters are there here. They use only 2 parameters, albumin and bilirubin. Remember, the 2 most important non-tumor variables that affect survival in hepatocellular cancer is albumin and bilirubin. Remember, albumin and bilirubin are not related to tumor. I told you jaundice is very rare in hepatocellular cancer, and low albumin is also quite rare in hepatocellular cancer unless and until cirrhosis is causing low albumin. That is different. But HCC as such will not cause low albumin. HCC as such will not cause high bilirubin. And if you have a low albumin and high bilirubin, that is an independent poor prognostic factor, irrespective of the tumor, background tumor. Remember, that is why these 2 are very, very important in terms of HCC. These are non-tumor variables that affect survival in a patient with hepatocellular cancer. That is why you have a separate scoring system for that is called as ALBI score. Then we have something called a CLIP score. CLIP score, you can remember by a mnemonic called PACE. That's the mnemonic I used to give. PACE is the mnemonic for that. So what PACE stands for? P stands for portal vein thrombosis, and A stands for alpha fetoprotein, and C stands for Child-Pugh score, and D stands for extent of the tumor extent. So extent means whether it's occupying more than 50% of the liver or less than 50% of the liver. So that is the idea. So based on CLIP scoring, if the score is 0 out of 4, I told you 4 variables. In that, if you have 0 out of 4, then we call it as stage 1. So if the score is 1 or 2 out of 4, then we call it as stage 2. And if it's 3 to 4 out of 4, then we call it as stage 3. So this is CLIP stage or CLIP scoring. In Okuda scoring, usually I used to give a mnemonic for the variables that's called BASE. BASE is the mnemonic for Okuda staging. B stands for bilirubin, of course, and A stands for ascites, and S stands for serum albumin, and E stands for extent of the tumor. Clear? E stands for extent of the tumor. So these are the 4 things that are important. So E stands for extent of the tumor. Clear? I think I have made a mistake on Okuda only. I think we are talking about Okuda, not for CLIP. CLIP is more, like heterogeneous. It will contain more of a scoring system kind of thing. So I can write the same for Okuda. Okuda, if you have a score of 0, then it's called as stage 1. Then 1 to 2, stage 2. Then 3 to 4, it is stage 3. That is why I should come in order, basically. Like I used to remember in this order, but suddenly, I went from the reverse order from bottom top. So that's why it's a confusion. So anyway, fine. So the staging is based on Okuda. So there's 0 variables, no variable, then it's stage 1. 1 to 2 variables, it's stage 2. Then 3 to 4 variables, it's going to be stage 3. So the mnemonic for Okuda staging is base, bilirubin, ascites, serum albumin, and extent of the tumor. So for CLIP score, again, you have a mnemonic called PACE. So P stands for portal vein thrombosis, alpha fetoprotein, Child-Pugh score, and extent of the tumor. So ALBI score, the 2 most important non-tumor variables, albumin and bilirubin. and BCLC incorporates a lot of things into it, which we'll be discussing after some time. Apart from that, we have something called AJCC TNM staging, so which has to be described separately. So what is AJCC TNM staging? In that we have T1, T2, T3, and T4. In T1, we have something called T1A and T1B. So what do you mean by T1A? T1A means size less than 2 centimeter. May or may not have vascular invasion, doesn't matter. T1B means more than 2 centimeter, but no vascular invasion, without vascular invasion. Remember, less than 2 centimeter plus or minus vascular invasion, doesn't matter, but more than 2 centimeter plus no vascular invasion, that is T1B. And then we have the T2 stage. T2, if the patient is having more than 2 centimeter tumor plus vascular invasion, or the patient is having multiple tumors, but all tumors should be less than, which means the largest tumor should be less than 5 centimeter, which means it can have multiple tumors, but all should be less than 5 centimeter, or the largest tumor I can tell it should be less than 5 centimeter. That means all tumors must be less than 5 centimeters only. That's the idea. Then T3 means the patient is having multiple tumors. Largest tumor is more than 5 centimeter, which means at least one. We're talking about at least one is more than 5 centimeter. And T4, invasion of major branch. I'm not talking about these minor branches of portal vein or hepatic vein, major portal vein. One of the major left-right branch of portal vein. Major branch of portal vein. Or invading adjacent structures. Invasion of adjacent structures. Clear? So remember, this adjacent structures will not include peritoneum. Peritoneum invasion will not be coming under this T4. Similarly, gallbladder invasion will not be coming under T4. That's very, very important. So you should exclude peritoneal invasion, gallbladder inflammation. Invasion. This invasion of adjacent structures will not include peritoneum and will not include gallbladder. This is a question exam. So this is one of the questions in 2016, I think in surgery. But remember, gallbladder invasion and peritoneum invasion will not be coming under T4, will not come under that invasion of adjacent structures, which is a key point to know. So this is T staging. And of course, you know, N staging, any node involvement, any regional node involvement will come under N1. Regional node involvement will come under N1. M1 means, you know, it's distant metastasis. That's all. That's all. As simple as that. So please understand, you need to know the staging of the disease. Remember, it could be TNE, but if you have N1 or M1, it becomes automatically, you know, like stage 4 disease. There's no doubt about that. If the patient is having T4, N0, M0 disease, it will be stage 3B disease. If the patient is having anything less than that, so T3, T1, whatever may be, doesn't matter. T3, T1, T2 or T1, and N0, M0, any one of these, T3, T1, and 1, it will be stage 1 or probably up to stage 3A. So why this difference is very important. So that's what I used to ask in the usual classes itself. So why separately I told stage 4 and stage 3B and stage 1 to stage 3A separately. Please understand, this is the definition of unresectability, which means you cannot resect. I mean, you cannot resect these tumors. Not possible. So these are resectable. That's why this is important. So please understand 3B and 4 are very, very important. So I mean, that's why final take home point is, if you have M1, if you have N0, if you have N1, any regional lymph node metastasis or any distant metastasis or a T4 tumor, or if you have these, definitely this is unresectable. So if in exam, if you want to know the definition of unresectability, if you have distant metastasis, if you have any regional lymph node metastasis, or if you have a T4 tumor, that is invasion of adjacent structures except gallbladder and visceral peritoneum. And second, if you have a major vein invasion or major vessel invasion like portal vein, invasion. So in that setting also, you will not be able to resect. So T4 disease unresectable, N1 disease not resectable, and M1 disease not resectable. So that's why this is very, very important. So that's why stage 4 and stage 3B are not resectable. Only stage 1 to stage 3A disease is basically resectable. So now with this understanding, if you go to the BCLC, it will be very easy. So as far as the BCLC is concerned, BCLC will incorporate a lot of this data into a single flowchart. It's very easy. You can just download a PDF from Barcelona Clinic Liver Cancer staging system, and you can see what are the points that are given. The same exact flowchart which I'm giving here will be there, will be given there also. You're going to see liver function test, liver function. Along with that, you are going to look for the tumor burden. Based on the LFT, I need to assess the CTP scoring, and based on the tumor burden, I need to see whether it is resectable or not. So why I want to do LFT? Because I need to know the CTP score. Why I want to know the tumor burden? Because I need to know whether it is resectable or not. So based on that, I can give a lot of data. So first one, I can tell the patient is CTP-A, and at the same time, the tumor is resectable. You know what is CTP-A? We have discussed already about the CTP scoring. So A, B, C is that child A, child B, child C. In that, the patient is having a child A LFT, liver function. And resectable means in TNM staging, it is stage 1 to 3A. So that's what it means by resectable. The patient is having CTP-A and a resectable lesion. So even though it looks resectable, it might not be resectable in the intraoperative exploration. During the intraop exploration, if you still feel it is resectable, you can proceed with complete resection of the mass. So this is what we refer to as something called partial hepatectomy. Complete resection of the mass alone by partial hepatectomy. Suppose if it is unresectable in the intraop, because in the intraop you can see some invasion of the tumor into the adjacent structures or invasion of the tumor into the major branch of portal vein. So in that setting, or you can see some nodes that are big and bulky inside the operation theater. So in that setting, even in the operation theater, you can deem the tumor to be unresectable. So what you're going to follow in that setting? So let us see. So it's going to follow the same protocol as that of other unresectable tumors. So let me tell, if the patient is having poor liver function, the setting of child B or child C, or if the tumor is deemed unresectable by tumor burden, which means the patient is having a stage 3B or a stage 4 disease, either a T4 or a N1 or a M1 disease. So in that setting, you have to see whether the patient is a liver transplant candidate or not. Please understand, liver transplant candidate or not is given by something called as a Milan criteria, which is very, very important. So what do you mean by Milan criteria? So there are many extended criteria are there. So the original Milan criteria is what is going to be asked in exams. Milan criteria means if you have a single lesion less than 5 centimeter, or alternatively, you have 3 lesions, up to 3 lesions. In the sense like you can have up to 3 lesions, but the largest, which means all lesions, or the largest lesion should be less than 3 centimeter, which means less than 3 lesions, less than or equal to 3 lesions, or 3 lesions, all should be less than 3 centimeter, or you can tell largest lesion should be less than 3 centimeter. Plus, along with that, patient should have no vascular invasion. Vascular in the sense, we're not talking about this small vessel invasion, we are talking about no major vascular invasion, which means it should not invade one of the major branches of portal vein. No major vascular invasion. They should be not having no M0 or no M1 or N1 disease. In the sense, the patient should have a N0 and M0 disease, which means the patient should not have any extrahepatic disease. The tumor should be well located within that liver itself. I mean, which means I'm trying to tell no N1 or M1 disease. In the sense, I can also write as it should be N0 or M0 disease. Then only it will be resectable by Milan's criteria. So this is the original Milan's criteria. Then we have many other criteria like extended Milan criteria. This is also referred to as something called as UCSF criteria. That is extended Milan criteria. Because of the Ankit is asking, sir, we enter the right wing of the flow chart, only 3B or More so, won't all the phase of million be already fulfilled? I'll come back to that. So if the patient is having a extended criteria, extended million means, what do you mean by extended million criteria? In the sense, in extended million, you need to see whether the patient is having a single lesion less than 6.5, because now the advancements are huge. That's why they have given a little bit of extra cushion. Single lesion less than 6.5, or the patient can have less than or equal to 3 lesions plus largest lesion should be less than 4.5 centimeter plus the total diameter of all the lesions. Total diameter of all the lesions, whatever lesions are there, should be less than or equal to 8 centimeter. So this is something called extended million criteria. So if you want to know, you can know this also. This can, I mean, this is something that can be followed because, like the surgery is becoming advanced and advanced more. So you can give an extra cushion. And even more advanced criteria is what we call as syllabus criteria. Syllabus criteria tells that you can operate even if there are 3 lesions, and they are given even more extra cushion that the largest lesion can be less than 5 centimeter plus total tumor diameter can be less than 10 centimeter. So this is syllabus criteria. So this is the most advanced, the most recent. At the same time, this should be followed only in areas where there is a tremendous expertise with hepatosurgeons. So in that setting, you can operate up to 3 lesions, largest less than 5 centimeter and total diameter less than 10 centimeter. Please understand, but this is the original Millions criteria, and this is what they will be asking in exam. Single lesion less than 5 or less than or equal to 3 lesions, all less than 3 centimeter. At the same time, the patient should have N0 or M0 disease and no major vascular invasion. What Ankit is asking is, when you enter the right wing, so already they will want all the features of Millen already be fulfilled. Actually, no. Remember, the patient may not be able to, may not be able to resect just because they are CTP-BC. They may not be unresectable. So in that setting, you have to see the liver transplantation. So because CTP-B and C, the ideal is liver transplantation only. So that is why, this Millen's criteria is typically destined for patients with CTP-BC, especially if there are problems with liver function. If the patient is having advanced liver failure, for those patients is where, Millen's criteria is most applicable. The patient is already unresectable, then for those patients, Millen's criteria will not be that applicable. But for patients who's having this abnormality in liver function, because of that, he will not be able to resect. So those patients is where you have to follow Millen's criteria very dedicatedly. So that's where the Millen's criteria will come into play more than this stage 3B4 disease. I think your question is answered. I hope this is the question that you're asking. I don't know what question you're asking, but I believe that this is the question that you're asking. So Millen's criteria is most applicable for patients with advanced liver failure. So rather than having an unresectable tumor. So you need to see whether the candidate is a liver transplant candidate or not. So by Millen's criteria, suppose if the patient is having, is a liver transplant candidate by Millen's criteria, then of course you're going to go for liver transplantation. Transplantation is the best option. But remember, there is something called bridging therapy. Till you take the patient for transplant, you have to debulk the tumor at the same time. You need to do some bridging therapy. So bridging therapy is better done with radiofrequency ablation or otherwise something called as TACE. So I'll talk about TACE. What is TACE? TACE stands for trans-arterial chemoembolization. You will either do a radiofrequency ablation or you're going to do a TACE, that is trans-arterial chemoembolization. Suppose the patient is not a liver transplant candidate, which means Millen's criteria is not fulfilled and the patient is not a liver transplant candidate, then you have to see the disease extent in this setting. Disease extent. If the patient is having an extrahepatic disease, which means N0 or M0, N1 or M1 disease. That's what I mean by extrahepatic disease, N1 or M1 disease. What you will do. And second, if the patient is having liver only disease, hepatic only disease or liver only disease, which means N0, M0 disease, that's what I'm talking about. What you will do in this setting, liver only disease. Once again, you have to see the liver function in both these patients. The patient is having CTP A or B. In this setting, you can go for systemic chemotherapy. I'll talk about that in some time. The patient is having advanced cirrhosis, CTPC, child C, then I'm going to go for supportive care and palliation. Just palliative therapy is what you're going to do. Similarly, in hepatic only disease, again, I'm going to see the liver function. If the patient is having CTPC, I'm not going to do anything, just supportive care and palliation. Supportive care and palliation. If the patient is having CTP A or B, okay liver function, probably in this setting, I need to see the next step, that is where the patient is having a portal vein thrombosis or not, which means portal vein invasion is there or not. So if yes or no. So if the patient is not having portal vein thrombosis or portal vein invasion, then in that setting, I need to see the number of lesions. So if the number of lesions is only one single lesion, plus it is less than 5 centimeter, then the best option is radiofrequency ablation. Other options include, there is something called microwave ablation is there. And we have something called PEI, that's called percutaneous ethanol injection. So we can inject ethanol into the mass as well. So, but nevertheless, RFA is the one that is most commonly performed, radiofrequency ablation. Then if the tumors are multiple, or if the size of the tumor is more than 5 centimeters, the size of the tumor is more than 5, it will not come under, I mean, we cannot put it under the RFA. It will be exceeding the RFA window. That's why size more than 5 centimeter cannot be treated with RFA. For this patient, STACE is going to be the best option. Transarterial chemoembolization. It will be done in a dedicated radiology center, or you can do something called radioembolization. Radioembolization using something called yttrium 90. I think I wrote 70, I guess. Yttrium 90 radioembolization can be tried, or you can do SBRT. Stereotactic body radiation therapy is what we refer to as SBRT. This is what you can do, but the most appropriate and the best option right now is TACE, transarterial chemoembolization, for these patients. And if the patient is having portal vein thrombosis already, then you have multiple options, but the best option will be radioembolization here using yttrium 90, or alternative will be SBRT, stereotactic body radiation therapy, or you can use a combination of TACE along with radiotherapy. But in this setting, the best will be radioembolization with yttrium 90. So this is what is going to be the flowchart for the treatment of liver cancers. In that, the only thing what we have not discussed is a systemic therapy. This is what is something we have not discussed. So systemic therapy, typically we use this tyrosine kinase inhibitors or multi-kinase inhibitors is what is the more appropriate term. The first line drug that we're going to use is sorafenib. And there are other drugs in pipeline like lenvatinib is there, and we have regorafenib. Remember, regorafenib is also used in colon cancer patients, regorafenib, and it's in pipeline. So, but the most commonly used drug as of now is sorafenib. Remember, the usual indication for sorafenib is patients who are having extrahepatic disease. This is a very common question in exam. Extrahepatic disease, unresectable, not a liver transplant candidate, having an extrahepatic disease, that is N1 or M1 disease, but having a okay liver function, good liver function, CTP-AB. This is the indication for sorafenib. And again, this will be asked in institute exams. So unresectable, at the same time, patient is not satisfying Millen's criteria, which means they are having extrahepatic disease, N1, M1 disease, which means they are not transplant candidates. At the same time, they're having okay liver function, CTP-AB. So this is the best indication for starting with sorafenib. So clear, CTP-C, irrespective of whatever may be the category, CTP-C means always palliative care only. There's no doubt. CTP-C is very simple. It's palliative care. CTP-A and B only will be having this kind of confusion. CTP-AB, unresectable and extrahepatic disease, you're going to go for systemic therapy. Unresectable hepatic only disease, depending on portal vein thrombosis, you can select. If there is a portal vein thrombosis, then radioembolization will be the best option. If there is no portal vein thrombosis or major vascular invasion, then you can try doing a TACE or a radiofrequency ablation. If it's a single lesion less than 5 centimeter, RFA will cover that. If it's more than 5 centimeter or if there's multiple lesion, then it's difficult to cover with RFA. Then in that setting, TACE will satisfy the demand. So TACE is the better option there. Apart from that, we have some other drug, that is a cabozantinib. Cabozantinib is something that is used for medullary thyroid cancers as well. Then we have something called ramucirumab. Ramucirumab. This is a VEGF receptor 2 inhibitor. And cabozantinib is also a tyrosine kinase inhibitor. It's a pro-invasive, which means it prevents the invasion of the cancer cell. So pro-invasive tyrosine kinase inhibitor is cabozantinib, and ramucirumab is a VEGF receptor 2 inhibitor. So these are the options for systemic therapy. They will be definitely asking you what are the indications for TACE and radiofrequency ablation. So where you can do TACE and radiofrequency ablation. So number one, the first indication is tumor downstaging. Tumor downstaging. So why? Remember, the reason why we use RFA and TACE here is not just as a end-stage therapy, it is also for tumor downstaging. Please understand, these patients are having hepatic-only disease, that is N0 and M0 disease. But because they might be having bigger lesions, they might be falling outside the Millen's criteria. Suppose if you are able to use this TACE and RFA, you might shrink the tumor size. You might shrink the tumor size and you can put them back into the Millen's criteria so that you can proceed ahead with the transplant. That's the idea. So that is why we do TACE and RFA. That the one most important thing why you do TACE and RFA is to put these patients back into the Millen's criteria and to make them a transplant candidate. That is the reason why you do TACE and RFA. Please understand that. Remember, once again, I'm telling you. So these patients are having hepatic only disease. That itself means N0, M0 disease. And these patients are not having portal vein thrombosis in the sense like there is no major vascular invasion. Satisfied. The only lesion why these patients will be going outside the Millen's criteria is because of the size of the lesions. So that is why we use RFA or TACE to downgrade the tumor, to bring the patients back to the, criteria where they can satisfy the Millen's criteria, and now you can take them for transplant. That is the idea. So that is the reason why you're doing a TACE and a radiofrequency ablation. Very, very important point. And second thing is as a bridging therapy. As a bridging therapy, I told you, even in patients who are transplant candidates, you can use RFA and TACE as a bridging therapy. I told you. So second indication is for bridging therapy. So these are the two most important indications for doing a TACE and RFA. These are two important reasons for doing a TACE and RFA, which is very, very important to know. So clear, I think the treatment part is a little tough and tricky, but still I think this will help you understanding. So what are the questions they will be asking you is this components of Okuda staging and components of clip staging. So I gave you the mnemonic already. ALB is very simple. No need to remember that because in exam you'll be remembering easily. ALB and bilirubin. These are the two most important non-tumor variables. Remember Okuda and clip. I gave you the mnemonic. Just remember that. And TNM, as I told you, the stage 3B and stage 4 are more important because they are unresectable. So any T4 disease or any N1 or M1 disease will become unresectable, as I told you, by default. And again, they will be asking you about certain indications. Liver transplant, definitely Millen's criteria. There's nothing about that. Newer criteria like extend Millen and Silvas. If they ask, you might tell. Other than that, you need not tell. Millen's is the most important. And apart from that, where will you TACE and RFA to downgrade the tumors so that you can put them back in the Millen's criteria. Second is, while awaiting transplant, you can use them as bridging therapy. And sorafenib indication in patients who are having systemic disease, in the sense, disease that is widespread, N1 or M1 disease, extrahepatic disease. At the same time, patients are not transplant candidates. Of course, they are not transplant candidates because N1, M1 disease is a contraindication according to Millen's criteria. And the mass is unresectable. Of course, N1, M1 disease is also an indication for unresectability. The patient is having N1 disease or M1 disease, but having a okay liver function, CTPAB, then sorafenib is one of the best options that you can do. So, once you practice this in an oncology center, this becomes quite easy. It's not a very difficult thing at all. Just by seeing the report itself, we can tell what is the probable therapy that you can give this to a particular patient. So I worked in oncology center for almost 2.5 years. So this is a very simple thing. HCC is in and out. They treat very easily. So sorafenib indication is very, very important. So which patients are candidates of sorafenib? So that's what is something because it's a very costly drug, that's why. So we need to decide on case-to-case basis. That's why these indications are very important. I hope I made this HCC a little easier and evaluation of all the liver tumors a little bit easier, so that that closes down this session. We'll see in the next express session, probably next Wednesday. I'll tell you the timing later on. I think with that, we'll close down this particular session. And thank you all. Thank you very much. Good night.